All right, so pharmacist interventions part 15. Most of these are recent, like within the last week, but I had a 67-year-old female patient picking up Celexa 40 milligrams daily, Buspar or Buspirone, 15 milligrams 3 times a day, Abilify 2 milligrams daily, and Bupropion 200 milligrams twice a day. And I was flagging for some interactions with each other. The Wellbutrin blocked the metabolism of the Abilify a little bit and the Celexa a little bit. So I was monitoring for like symptoms of too much or one or the other. I was asking about, of course, palpitations. Celexa was at its max dose, and it's actually a little higher than what's recommended for older patients. But I figured out this patient was dizzy, experienced a lot of dizziness lately. All these medications can cause that, mainly probably the Buspar and maybe some of the Wellbutrin. It's not good for an older patient to be dizzy because that poses a fall risk, and then patients, especially female patients of higher age, are at risk for fractures. So I told her to follow up with her provider about that and see if we could decrease the dose or one or the other and figure out what's making her so dizzy. Another intervention was I had a caregiver picking up a antibiotic for a 1-year-old, and it was I noticed that they picked up some recent prescriptions of both amoxicillin and Augmentin for this 1-year-old. So I stopped by and was like, hey, what's going on? And it seemed to be either reoccurrent or an ear infection that just wasn't going away, like an acute otitis media, an inner ear infection for the 1-year-old. And I ended up counseling on what the signs of C. diff were. C. diff is a pretty dangerous infection for patients, and it's usually when you have a lot of recent broad spectrum antibiotics. So I talked to the caregiver about some fulminant diarrhea, some really profuse watery diarrhea, multiple a day. And then I also talked about possibly blood in the stool. And then I also told them that the ceftonir could also color the stool orange. So that's what I talked to him about. I actually did have a pediatric patient, I think it was a year or two ago, when I was an intern, a caregiver told me that their kid actually got C. diff from something. So I thought about that when I was talking to him. Another one was today. I had a patient who's my age and she called and she said, I have a drug interaction question. And I was like, oh, excellent. I'm perfect to ask for this. And she said that she was taking Flexeril and Zoloft. And she was like, I don't know what's happening, but I'm waking up in the middle of the night. And I feel I just don't feel good. My skin's crawling and I'm sweating. And I was like, okay, well, that might be some sort of mild serotonin syndrome coming from both of those that you're taking. So she's like, well, what do I do? Do I space it out? And I was like, well, I know that Flexeril is usually 3 times a day. And I was like, it sounded like she was taking it twice a day. And I said, you can try taking the Flexeril at night and the Zoloft in the morning. But I said that you probably will still have some sort of side effect by taking them. Zoloft has a 26-hour half-life and it stays in the body pretty long. But I said maybe try with one. If you still have that side effect, I recommended maybe trialing tizanidine, another muscle relaxant, or asking the provider about that because it doesn't have a serotonin increasing effect. It is an alpha-2 agonist. So it's alpha-2 is a heteroreceptor. So when you have a drug acting on that receptor, it decreases the output. It's a negative feedback, so it decreases sympathetic output. The last one I wanted to talk about was I had a patient who was prescribed a lot of opioids. It was Oxy, 10 milligrams, and she was supposed to be taking 4 of them every 4 hours. And then she also got prescribed morphine 15 extended release 3 times a day and morphine 60 3 times a day extended release. And I was like, that's kind of a lot. I pulled up her inspect report to make sure she's opioid tolerant. This is not a patient who is new to opioid therapy because I had no history on the patient. And I saw a fentanyl 50 patch picked up and Oxy 30 recently picked up. And I was like, oh my goodness, what is going on? So I called the hospital and I got a hold of the provider, and the provider was a little confused. She was like, what? I didn't prescribe any fentanyl. When I asked about the fentanyl, and I was like, oh, well, there's recent history that she was on fentanyl. She had no idea. And then I was also relaying the information, the morphine that you sent over requires a prior authorization. She's like, oh, well, how do I do that? And I was like, oh dear, you can call the inpatient pharmacy because they're going to walk you through it. They can help you. They can actually file it on your behalf. So I recommended that I have the inpatient pharmacist call me, or one of the pharmacists. So about like maybe like 20 or 30 minutes later, I got a call, and it was one of the inpatient pharmacists, and I was like talking to her. I'm like, what is up with the fentanyl patch first? And then she said, oh, that was being discontinued. We're switching her to morphine. And I was like, okay. And then I also figured out the provider meant to send in the oxy, the 40 basically every 4 hours if needed. It wasn't supposed to be scheduled. So we canceled that prescription, had her resend the as needed one. And then I told the other pharmacist about the PA with the morphine, and she started those. There's just a lot of miscommunication with that. And the caregiver ended up coming to the pharmacy and was like, yeah, the provider said everything was ready. And I was like, it's not already. It's just the Narcan and the oxy. There's a PA on the morphine. I told her about all that. And I asked her too about the fentanyl because I was curious, and she said that it was overly sedating the patient. And I was like, also like, what's going on with the patient? Because there wasn't a diagnosis code that came over either. And that she was telling me about the stage 4 cancer that she had. So I discussed that. I would recommend like having her like consult either pain management, an oncologist, or some sort of pharmacist within that realm about switching between the opioids to make sure that it was both an appropriate dose, like managing the pain, but also like not too much and overly sedating the patient. Because the morphine mill equivalence was like 500 to 85. That was set in for the 2 morphines and the 40 oxy, and the oxy 30 that was previously on, I think, was discontinued and dose increased, but it was just a lot. It had me stressed out because it was like there was no communication with me. I had to like search for it and be like, where is this all coming from? This is kind of a lot. Like I need a diagnosis code. I need to know what's going on with this. I can't just prescribe or like allow the dispensal of all these products on my license and for the health of the patient. But we ended up kind of figuring it out, and pain management was going to take over the PA for the morphine from there. I know this is a longer pharmacist interventions video, but that last one I wanted to talk about a little bit.